a tumor which can occur in relatively younger group also. And if it is invasive, it is a fatal disease. So it's very important to diagnose it early and treat it early. Secondly, it could be both etiologically HPV associated, or it could be independent of HPV. Then whenever a patient comes with a penile lesion, there could be a differential diagnosis, could be infective, inflammatory. It could be a lesion, which is benign. It could be a malignant. And then there is a condition called PIN, intraepithelial neoplasia, which are carcinoma in situ. So these are like erythroplasia, Kierat, Bovinoid papulosis, Bovinoid disease. All these will come under carcinoma in situ of the penis. So very important to understand all these. And then once you have taken the biopsy, proven it, then we have treatment available, which will depend upon the risk stratification. So if it is a low risk disease, we may do organ preserving kind of treatment, which will include kind of a topical application of 5-FU or 5% imiquimod, or laser therapy, or Mohs micrographic surgery, or even glands deepithelialization and resurfacing of glands. And sometimes a partial organ preserving would be partial glandsectomy or a glandsectomy, right? And if you're not able to do, or it's a high-risk disease, then you should go ahead with do a partial amputation if you can preserve the optimum size of the penile shaft. If you cannot, then you do a total amputation. As I said about total penectomy, usually you do not go up to the crest, you do go just up to the base of the penis. So if you have to go to the crest, if you think that it is going down up to the crest, then it's a radical kind of a penectomy. Then again, it is very important to understand that even if the lymph nodes are not palpable in a penile carcinoma, in high-risk disease, there is a 10 to 40% chance of micrometastasis in the lymph nodes. So it is important that we do lymph node dissection in every patient with high-risk disease. It is done bilaterally. It's very important to understand that, because once it goes into the lymph nodes, it becomes an invasive disease and becomes fatal to the patient. So again, once we do this, then we need risk stratify it into low-risk group or high-risk group. If it is a low-risk group, then active surveillance is probably the treatment of choice. And if the patient is not compliant for surveillance, or it is a high-risk disease, then we should go ahead and take lymph node biopsy. Either it can be taken as dynamic sentinel lymph node biopsy, or it could be superficial inguinal lymph node dissection, which could be done open, robotically, or laparoscopically, right? And if it is a high-risk disease, non-palpable nodes, then we should again go ahead, as I said, with this kind of superficial. If it is positive, then we have to do a total inguinal lymph node dissection. If it is a palpable nodes with high-risk disease, then we have to again take a biopsy and then go ahead accordingly. So as I said, either take a FNAC if it is a unilateral palpable lymph nodes, and if it is proven positive, we go ahead with a therapeutic inguinal lymph node dissection. Or if you do a superficial inguinal lymph node dissection, take a frozen section biopsy. If they are positive, go ahead with a therapeutic inguinal lymph node dissection. If there are more than 2 lymph nodes positive, or if there is an extranodal extension, or if there are bilateral inguinal lymph nodes, you have to do a pelvic lymph node dissection. So these are, and before, if there are lymph nodes palpable, you always do a CT, MRI of pelvis. If there are pelvic lymph nodes positive, then you have to take a percutaneous biopsy from the pelvic lymph nodes. If they are positive, then we might even do a neoadjuvant chemotherapy followed by a surgery or just a chemotherapy in those patients. So this was basically and about chemotherapy. If it is a metastatic disease or the pelvic lymph nodes are positive, then definitely you have option of chemotherapy or chemoradiation. Now we have certain radiosensitizing agents also, like cisplatin, and even immunotherapy. Pembrolizumab acts as a radiosensitizing agent, where you can go ahead, first give this and then followed by chemotherapy. Chemotherapy, if there is a response, there is one other option of doing a consolidative surgery. If there is a response to chemotherapy, if there is no response, then you go ahead with the second line chemotherapy or a salvage chemotherapy, or as a symptomatic treatment to these patients. So if the disease is kind of invasive, most of these patients, if not treated properly, it would be fatal, and the patient dies either of sepsis, hemorrhage, or distal metastasis in the liver and lungs. I think basically this is in nutshell about carcinoma penis. I think we should be aware of this disease, particularly in our part of the world where it is not that uncommon. So any query from the residents? Nachiket, if you want to say something. Dr. Dharmendra? If nobody has anything to say, and if I don't find any thing in the chat book also. So thanks everybody, and thanks for joining us today, and have a good day.